The idea for this particular topic came because I gave a talk to my own group, and many people had said that they're not very good in statistics and would like to refresh some of the concepts that are required to even read the literature properly. And that is something that is very important in the sense that not only to deliver good care to our patients, but even to be able to read literature properly and interpret the various trial findings correctly, we must have a clear idea about certain concepts in statistics, which we read almost every day in the papers. So I will briefly touch about several. It will not be a very complex talk in the sense that I will not talk about how various parameters are derived by statistical calculations and details of the models, but I'll talk about how we can improve our knowledge about various tests which are done in statistics and how to interpret those correctly in our day-to-day practice. So coming first to the clinical research universe, we know that at the top of the line, the best evidence quality is in the either research guidelines or in the systematic reviews and meta-analysis. And then we have randomized clinical trials. These two are very important, and others don't fare so well as far as the quality of evidence is concerned, like case control studies, cohort studies, cross-section. They all come lower down in the hierarchy. Case series and case report, they come in the last. But today I will confine my discussion to an unbiased randomized trial as to how it is performed and how we should interpret a randomized clinical trial. Now, just a moment. Now these trials are conducted. Now the trial is basically planned to test effect of a drug or intervention or exposure on a group of people. And for example, there may be a huge number of patients, say 5 million patients with a disease globally, and we want to study that particular disease. That number is called a population, and we can only study a sample and try to apply results to the entire population. So we take a sample from that particular population, and then we try to study. Now, when you do that, you take a small sample, there will always be some uncertainty. Now, that is the key to today's talk, because statistics is not a pure science in the sense that it cannot give a very precise mathematical calculation. It gives you probability. So all statistical models, they basically quantify the uncertainty for us. So they use probability to quantify uncertainty and help us take decisions. So that is what statistics does. All the models are designed to quantify uncertainty. Now, sometimes it may happen that you do more than one study. So if you do two studies with different population, different samples from the same population, different results may be obtained by different researchers in the same population. And that may also depend on the sample size and various other parameters, but it is quite common. And that also leads to some discrepancy also. For example, if you do 50 studies all over the world in the same population, and different trials will report different results. And it might quite happen that out of 50 trials, 45 are negative and 5 are positive. So the 5 positive get published, and out of 45 negative, maybe only 2 are published. There is a publication bias. And when you do meta-analysis, you find that the results are quite good. So the thing may get accepted, even though 45 studies were negative. Now it's happening that the recent people who are doing systematic reviews and meta-analysis, etc., they are trying to incorporate data from the unpublished trials as well. There are trial registries from where you can get the data which is submitted for approval of the trials and subsequent reimbursements. And also all that data is there in the registries, which can be obtained, and one can do a better meta-analysis and better systematic review. Now, when we take a population, a sample, we randomize it into 2 or 3 groups depending on our trial. And randomization is itself a science. I will not discuss the details of randomization, but if randomization is done properly, it makes the group similar in every aspect except for the exposure that we are trying to study. And that exposure could be a new medicine, it could be a new procedure, it could be some implant, it could be some other intervention, it could be exposure to yoga, it could be exercise, it could be prayers, anything for that matter, any pollutant. So any exposure, anything which is different is called exposure that we are trying to study. The important thing about the randomized clinical trials is that they should conform to 3 or 4 important principles. One, the most important is that the group should represent the population that we are trying to study. So we have to have a good sample size. If we take a, hello? If we take a very small sample size, it may not represent the population that we are trying to study. Second important thing is that the randomization should be done scientifically and should be maintained throughout the trial. Third important thing is that the group should receive treatment as prescribed. There should not be much deviation. And fourth important thing is that there should not be much dropout on follow-up. So if you maintain these 4 things, then the trial can give a good result or more accurate result. Now, one of the recent trials, which somebody had requested me to allude to also, CABANA trial, it basically, it's a minefield for statisticians because it provides us so much opportunity for statistical discussions. We can continue to threadbare analyze that trial for hours together and we will not reach anywhere. So coming to these 3-4 principles, let us see what happened in CABANA. So 2,200 patients were randomized to 2 groups, 1,100 to catheter ablation arm and 1,100 to drug therapy arm. The problem with the trial was, so one thing was quite good, that the population was very good in the sense that we had a large sample size. It's a very large sample size, and the follow-up was planned for several years. So the trial whole lasted, about 7-8 years. So it was a very well-planned trial. But the problem was that about 100 patients, that's about 9%, did not receive catheter ablation in the catheter ablation group. And in the drug therapy arm, about 300 patients received catheter ablation. So there was a lot of crossover from both sides. So that became a big problem. And when the ITT analysis, so this trial was analyzed in 3 different ways. Normally, it has been a convention for last 40, 50 years that we analyze a trial by intention to treat analysis. Intention to treat means that we keep everybody in the same group as randomized because we want to maintain randomization. So we don't change over anybody. Anybody may receive any treatment, but will be counted in the same group. So when ITT analysis was done, it was found that there was not much difference in the 2 groups. Another thing which happened very wrong with this trial is that in midway through the trial, they changed the primary outcomes and secondary outcomes. So they reversed them, they switched them basically. So secondary outcome became primary and primary became secondary. So that was not a right thing to do. Anyway, despite that, the primary outcome, they did not find much difference, significant difference. So they tried another analysis, which is called treatment received analysis, where what they did was that they clubbed the patient, supposing in the drug therapy arm, 300 patients received catheter ablation, they were clubbed with the catheter ablation arm, and the patients who did not receive catheter ablation in the catheter ablation arm, they were clubbed with the drug therapy arm. So they tried on treatment or treatment received analysis. So that was one thing that was done. And a third type of analysis was done, which is very rarely done actually, which is called per protocol. So there are very few trials that I know of that would have all 3 types of analysis. In the per protocol analysis, what they did was that in both the arms, people who crossed over, their data was not considered. So in the drug therapy arm, patients who underwent catheter ablation, they were not considered for analysis. And in the catheter ablation arm, patients who had catheter ablation not received, they were not considered. This is called censoring. So censoring of data occurs when patients die of unrelated things, or they exit from the study for various reasons. Somebody may migrate, somebody may withdraw consent. So they may exit from the study for various reasons, and the data is considered to be censored. So this also became a problem subsequently for interpretation, because if you censor so many patients, like for example, 100 patients had, they were as such, they withdrew consent, and 300 patients, so about 400 patients or 40% patients were not analyzed properly among the drug therapy arm. And also in this also about 200 patients were not analyzed, so they were censored. So a lot of follow-up loss was again became a big problem too. In neither of the three ways, this trial could be analyzed properly. The main problem with the treatment received arm, this appeared logical to many people, but the problem with this is that if you club all the ablations to one side and all the drug therapy to one side, then you don't maintain randomization. So that is a big problem. The groups then don't appear compared. They cannot be compared because the randomization is lost. The randomization is maintained in ITT and it is maintained in per protocol, but it's not maintained in the treatment received analysis. Now coming to how we interpret the p-value, or a process that is called hypothesis testing. Now, when you start a trial, you begin with the assumption that both the groups are same. Of course, you're doing the trial to find the beneficial effect of the new treatment or new drug or new intervention. But statistically, we begin with a null hypothesis, which is represented by the letter H0, which means that there is no difference between the groups. So that is the default, that null hypothesis is valid. And of course, we have an alternative hypothesis, which is depicted by the letter H1 or HA, which means that there is a difference between the groups. So these are the two hypotheses. And of course, we begin with the null hypothesis. That is what and we hope to reject it based on the trial result. We hope that there will be difference in the two groups, and which will make our null hypothesis invalid. And we will be very happy to reject it in favor of alternative hypothesis. But that is what we hold for the moment while the trial is going on. We hold this belief and we hold this hypothesis that there is no difference between the two treatment groups. Now, the important thing to understand for the trialists is that there is no way to prove whether null hypothesis is true or was ever true, because you are not seeing, you're not studying the whole population. You're studying a small sample, as I said in the beginning. So it will never be possible for us to know whether the null hypothesis is true or false, but the data will tell us the probability as to how incompatible the results of the trial are with our held position of null hypothesis, that we believe that both groups are same. So these are the important points about p-value, that p less than 0.05 does not prove that the intervention or the drug is effective. Secondly, p more than 0.05 does not prove that the intervention or the drug is not effective. Third point is that p less than 0.05 does not indicate probability of trial results being true. What it indicates simply is the probability of obtaining a data as extreme as we are observing the trial, given that the null hypothesis is true. So that's all the p-value tells us. And based on this probability, we are supposed to either reject the null hypothesis or do not reject it, and we declare the trial negative. So Dr. Paul Wakim of National Institutes of Health, USA, he gives a very good analogy, that is a coin toss analogy, and that is the best analogy I have seen, which explains the relationship of P wave with the trials. So this is how the analogy goes. So imagine I propose to you that I have a coin with head on both sides, and you are expected to believe that. You say, I don't believe it, but it has important implications. You might be finance minister, you may have to order important investigation throughout the country. So you want to know also that whether I have a coin with the two heads or not, but you don't want to believe it easily. So you say that, show me the coin. But I say, I cannot show it, but you have to believe it. Your hypothesis is that I have a normal coin. So that's the null hypothesis. And you want to see the coin to confirm it. I say, no, you cannot see the coin, but we can offer an experiment. So I say, okay, I will toss the coin because it is a double-headed coin. It should fall on the head. So I toss the coin and the coin falls with the head side up. So I say, see, I told you it's a double-headed coin. So it's come like this. But you can say that, no, the possibility of this happening is only 50% with a normal coin. So I'm not going to believe you at this point. So we repeat the experiment, and 2 times out of 2 times, we get the head up. Now the possibility of it being a normal coin or null hypothesis being true is only 25%. You still don't believe. You don't want to give up your null hypothesis. So we do more experiment. Now it's 3 out of 3. And now the possibility of the data being compatible, now the data is getting more extreme. It's showing difference. So the compatibility with the null hypothesis is getting smaller, and it's not supporting that. Now it's only 12.5%. And we do more experiment, and again, it's like 4 out of 4, it's head. Now it's really changing the mathematics, and it's got you thinking that it might be a double-sided coin. So, but it's still, the possibility is 6.25% of it being a normal coin. So that corresponds to the p-value of 0.0625, which is conventionally not the threshold at which you reject null hypothesis. So you want some more experiment, and 5 out of 5, when 5 out of 5 it's head up, then you reject your hypothesis. Then you say, now the p-value is less than 0.03. I have not displayed the coin, nothing is proven, but the data is incompatible or showing less compatibility. So the p-value is a measure of compatibility of data with null hypothesis. And at some point of time, whatever threshold we set conventionally for last 1 century, the threshold had been set at 0.05. We will discuss a lot about that as to what is so special about this threshold and why shouldn't we discard it. But that's separate discussion. But conventionally, we hold that threshold in mind. And when we find that the data is quite extreme and the probability of that data being so extreme with the null hypothesis less than 0.05%, less than 0.05 or 5%, then we reject the null hypothesis in favor of alternative hypothesis. So once again, to repeat those points, the p less than 0.05 does not prove that the new treatment is effective. P more than 0.05 does not prove that the new treatment is not effective. P less than 0.05 does not indicate the probability of trial results being true. P value simply indicates the probability of obtaining a data as extreme as observed given the null hypothesis is true. So again, I will say the same thing again and again in this talk, that the statistical models, they use probability to quantify uncertainty. Whenever we do a trial, there will be uncertainty, and all we want is quantification of that uncertainty so that we can take a proper decision in one way or the other, because we have to give a binary decision to a continuous issue. And that probability is a continuous process, and we have to, at some point, we have to set a threshold to get a binary decision that trial is positive, trial is negative. But that's where the problem comes, because if you set this probability at less than 0.05, it can still be a normal coin and your conclusion was wrong. This is called type 1 error. That is when you reject the null hypothesis when it was actually true. But because you saw the probability being very low, you reject it, but it was true. And that is called type 1 or alpha error. And conventionally, because the threshold is set at 0.05, so the error, the chances of type 1 error or alpha error are around up to 5% or less. Secondly, it may also happen that you have only this much data. For example, you are conducting a trial and your pre-specified number was 500 patients. You included 500 patients and they were supposed to follow, you had declared in your trial that you will follow them for 3 years, and you followed them for 3 years. And at the end of the follow-up, you find that the p-value is coming to 0.625. Now, what do? You have done a lot of hard work and the p-value is coming 0.06. Do you accept or do you reject your null hypothesis? Obviously, with the conventional methods, you're supposed to reject your null hypothesis and accept alternative hypothesis. So you're supposed to hold the null hypothesis that and reject the alternative hypothesis and declare the trial as negative. And that is called type 2 or beta error. So type 1 error is when you reject the null hypothesis when it is in fact true, which means that we declare the investigational treatment effective when it is not effective. So it can be called a false positive reporting of the effect. Typically, it is less than 5%, 0.05. Type 2 error is when one fails to reject the null hypothesis when it is actually false. So, which means that we declare the investigational treatment ineffective when it was actually effective. So that's a false negative reporting of the effect. And it should ideally be less than 20%. How do you measure that? We measure it by the power. So typically, we want sufficient statistical power in the trial, and which is calculated as a 1 minus beta error. So it should be more than 80% or zero 0.8, which means that the beta error should be less than 20% or less than 0.2. And these things should be calculated a priori, because unless you calculate the a priori means before the trial. So if you, unless you calculate the power before the trial, it's not valid. So it should guide the sample size, it should guide the follow-up duration based on the historical data, based on previous studies, and expected difference between the two groups. So this is a very important point, that how, I will not discuss how to calculate power, we will leave it to statisticians for the moment, but we must take a guide from the sample size, follow-up duration. All these have to be decided based on the historical data and expected difference between the groups, and we create the power by deciding on the adequate sample size and adequate follow-up. Now coming to another important thing that we see, confidence intervals. They are there in every trial, and most of us know what is a confidence interval. But to refresh and for benefit of youngsters, I will repeat as to how these, what the confidence intervals mean and how they are computed. So supposing as a buyer, you want to buy oranges, and but you want to ascertain their quality, and you want to know the mean weight of oranges. So you, supposing you take 50 fruits out of this, and you calculate the mean weight of the oranges, and you calculate the standard deviation, you come to have some idea about the quality of oranges. But if you want to know what will happen if I repeat this experiment several times, will it be same? For that, you have to go to confidence interval. And usually confidence intervals are calculated at 95% confidence level. They will give you a range. Confidence interval means there is a range which is supposed to contain the true value. If you repeat the experiment endlessly, it will include that value 95% of the time. So this confidence interval gives you the information that this center point is called point estimate, and there is a lower bound, there is an upper bound, and the entire range indicates the interval or the range of weight here in this case, which will include the true mean weight of the oranges if 95% of the time, if we repeat this experiment endlessly. If you want a better quality of estimate, you want a narrower confidence interval, you have to increase the sample size. So if you increase it to 500 fruits, it will give you a narrow estimate. If you further increase the number of fruits, it will give you a further narrowing of the confidence interval. So you get more, your uncertainty becomes less. So this is another important concept, that as the sample size increases, the confidence interval shrink, which means your uncertainty also shrinks. Of course, if you want a absolute correct estimate, then you have to measure every fruit and count every fruit, and that will give you a true estimate of the mean, unless you of course fail in the count. So that is important. So confidence interval is a range of values which will contain the true value 95% of the times when the experiment is repeated. And the width of the confidence intervals indicates uncertainty about that value. And that's how this distribution, I will not go into the details of this, most of us know it, that is the Gaussian distribution. And when you have a mean of any value, this is, it will include, if we have one standard deviation, and on either side, it will include about 68.2% of patients. Two standard deviations include 95%, 0.45, and three standard deviation includes virtually all, so 99.73%. So I will not go into the details of this distribution, but confidence intervals are reported in every trial. And this is not only for the mean, they are for every value. Like if you have hazard ratio or whatever value you have, it will have a confidence interval. Now coming to a typical trial. So for example, we have a drug which is being tested against existing drug. So drug A is the new drug and drug B is the old drug. And we are testing this drug for, say, stroke reduction. It may also be a placebo, but in this case, it's an existing drug. So for the purpose of this particular presentation, we say it's a drug A and it's drug B. And we typically, they are represented in like this kind of graph, where we have this vertical line, which is called the line of no effect, because when you measure the hazard ratios, if the hazard ratio is 1, which means that both the drugs are same. So this is the line of no effect. And when you do a trial, as I said, the null hypothesis will be that there is no difference between the two drugs, drug A and drug B. But the alternative hypothesis will be that there is a difference between drug A and drug B. And you hope to show a difference, a better performance by drug A. So what you do is you take 4,000 patients in this example, and you divide them into 2,000 each. So 2,000 patients are randomized into each arm. And drug A, which is the new drug, shows 4% incidence, and the drug B, which was the existing drug, shows 5% incidence. So there is a 1% absolute risk reduction, which will translate to 20% relative risk reduction, or the hazard ratio becomes 0.8. And there will be a confidence interval. So if you see, this is 0.8, and there will be a confidence interval. Say in this case, it is 0.68 to 0.96. So from 0.68 to 0.96. And I have drawn these slides myself, so it may not be 0.96 exactly, but it's on this side of the line, on the left side of the line. So the entire confidence interval is falling on favoring the drug A, which means that even if you repeat the experiment 95% of the time, it will show benefits. So that is your confidence level, basically. So you can reject your null hypothesis that, yeah, you can say that the drug A is actually better than drug B, unlike your null hypothesis, which maintained that both the drugs are same. Now see what will happen, the effect of a reduced sample size or a smaller sample size. Supposing instead of 4,000 patients, you had taken only 2,000 patients and divided them into 1,000 patients each. What would happen? Your confidence intervals would get wider. And see what happens. If you change it to 2,000 and 1,000 each group, the point, everything remains same. The drug A has 4% incidence, 5% incidence, absolute risk reduction, everything is same. But because of lower numbers, the calculated confidence intervals are wider. And the upper bound now touches or even exceeds the line of no difference. That is when the trial results become non-significant, because now the p-value will be more than 0.05. So you call them non-significant. And the same thing happen if the drug is less effective as compared to the drug B. It's on the other side. So we have again 2,000 patients, 1,000 each. But if you increase the sample size, you can say that it is now the confidence intervals are narrow, and you can say that the drug is clearly less effective as compared to drug B. So that's how this is called superiority trial, where either of the drug or placebo may be more effective or less effective than the other group. And that's how you interpret these trials. And in a typical paper, you find this kind of graph where you see in all patients, you see the point estimate, you see the confidence intervals, and then they do subgroup analysis, and different subgroup, they will show you what is the exact confidence interval and what is the point estimate. So then you can make your interpretation that whether it was effective. For example, here in the QRS duration, you can see that in less than 150 millisecond, it is not effective, or CRT ICD. In this case, in the bottom, you can see what is ICD only better, or CRT ICD. This from, I think, Medit CRT. And so it was in the widened QRS patients, CRT plus ICD was clearly better. So this kind of interpretations you can draw from this graph. Now we come to non-inferiority. Now this is a bit difficult to grasp. And this thing, it has cut in my consciousness for quite some time before I was able to grasp it completely. Basically, what happens is that sometimes we have existing drugs. Like, for example, you have several statins or you have several NOACs, and some industry wants to launch a new drug. And they want to compare the drug against existing drug, which is already approved by the regulators. And instead of doing a superiority trial, they want to do a non-inferiority trial. They just want to prove that the drug is not inferior to an existing drug. So in this example, again, we have, for example, 4,000 patients. We will divide 2,000 in each group. And we have to calculate the hazard ratio with drug A, which is the new drug. as compared to drug B. Obviously, we want a better result with the drug A. That's what we're doing the trial for. And in this case, the null hypothesis is that the drug A is inferior to the drug B, because the alternative hypothesis is non-inferior. We are doing a non-inferiority trial. So the null hypothesis has to be that the drug A, or the new drug, is inferior to the existing drug, that is drug B. And the alternative hypothesis will be that the drug A is non-inferior to drug B. Now, when we want to do a non-inferiority, we have to prove inferiority with a margin. So we have to create another line which is called non-inferiority margin, or the delta. So the inferiority has to be proven to be very significantly inferior, which means simple crossing this line will not be enough. The center line will not be enough. The drug has to cross a line which has a delta value, only then it will be called inferior. So for example, if we do the study and we find that the new drug had a hazard ratio of 1.5. So we were testing it for, say, for example, the same thing is stroke reduction, but we found that the new drug has a incidence of stroke of 6%, while the existing drug had an incidence of 4%. So the new drug has a high risk of about 2% in absolute terms, and the relative risk is 50% higher. So the hazard ratio becomes 1.5, and the confidence intervals are 1.32 to 1.69, which is on this side of the line, because this line is at 1.3. So this is the delta, or the non-inferiority line, and the entire confidence interval is on this side. So you can clearly say that the drug A is inferior. But what happens here? Here you find that it is less inferior when we have a difference, less difference. For example, the drug A has 5% incidence, drug B has 4% incidence, and the risk, absolute high risk is 1%, the relatively high risk is 25%, and the hazard ratio is 1.25, then this line is touching this line. So still we say that the drug is inferior. The upper bound, this is, as I said, in the confidence interval, we have the point estimate, we have a lower bound, and we have a upper bound. So in a non-inferiority study, the upper bound has to come within this line for the drug to be called non-inferior. And this is what may happen in the next setting. So here we have drug A having a 5% incidence, drug B having 6% incidence, and we have a confidence interval which is between the two lines. Now this is where the difference lies. In a conventional study, or what we call superiority trial, the drug would have been called inferior, but here we call it non-inferior because it has the upper bound of the drug, upper bound of the confidence interval is now within this line. So in this setting, the new drug will be called non-inferior because it is within the non-inferiority margin that we had set. So the question comes, who sets the non-inferiority margin? Obviously, if we set a wide non-inferiority margin, the drug which is being tested for non-inferiority has an advantage, and it may be approved despite being actually inferior. If you do a superiority trial, it will come as inferior. But here, because we have set a non-inferiority margin, it is considered non-inferior. So who sets this line? It is, of course, the trialists who set the line, and the method of calculating it is somewhat imprecise. It includes a lot of data from the previous trials, from the expected difference, and a little bit of subjectivity also. Therefore, non-inferiority trial is not considered as good as a superiority trial, but that's how it is done. And of course, if you find less difference, then again, it will still be called non-inferior. It will still be called non-inferior because it is on this side of the line. So it will be called non-inferior. And if it crosses the line completely in this, as in this example, then the drug A becomes superior. So it is inferior if it is on this side of the inferiority line. If it touches it, it is still non-inferior. If it is within this line, then it is called non-inferior. If it touches this line, non-inferior, non-inferior. And if it crosses the line completely, both the lines, then the drug A becomes superior. Now, all of us have seen RELY trial. Now, a RELY trial was done basically to prove non-inferiority of dabigatran against warfarin. But all the values, they were eventually calculated for like superiority trial. But you can see in dabigatran, here we have 110 milligram and here we have 150 milligram. The 150 milligram showed superiority in every which way. So it showed a very good p-value for superiority. And of course, it will show for non-inferiority also. But the 110 milligram dose did not show a good p-value with the superiority analysis. It was significant only with the non-inferiority analysis. And that is the data. So if you see the trial, if you see the data, this is for 110 milligram, this is for 150 milligram. And this is the text from the same trial, RELY 2009. The statistical analysis part says that to satisfy the non-inferiority hypothesis, the upper bound, this is the upper bound. So the upper bound of the one-sided 97.5% confidence interval for the relative risk of an outcome with dabigatran as compared to warfarin needed to fall below 1.46. So this is the line they drew at so far away from the line of no difference. This was the line which was drawn. So if this had shown, if this point, the upper bound had come up to this point, within this line, it had to come within this line of 1.46 to be considered non-inferior. So that was a very big, wide margin. Of course, it ended up being superior in 150 milligram dose and non-inferior in 110 milligram dose by a significant margin, but that's how the trial was designed. Another point about p-values is the way they were depicted earlier. So there was a phase in about 40, 50 years ago when the trials used to report p-value like this. So it was all non-significant, 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 and only the significant values were shown and everything else was non-significant. So there was no way of knowing from this particular table as to how much difference, what was the probability, exact p-value, because you would like to know how narrowly the p-value missed significance. So that's a very important point to know, because we cannot be totally dependent on a particular threshold for the p-values. So for that reason, it has been now made customary, and all the journals basically they want it that the p-value should be reported as it is. Another way to report p-value was here, like p less than 0.05. So wherever p-value was significant or less than 0.05, they were marked with a symbol, and it was reported at the bottom that this symbol signifies p less than 0.05. So this is not the way p-value is reported or should be reported. It's reported like this now. So you report the exact p-value so that you know how badly it has missed the significance level. So what is the exact probability of the data not being compatible with null hypothesis? So here you find that in this CABANA trial, so if you look at the mortality data, the p-value is 0.38. So that means that there is a 38% chance of the data not being compatible with null hypothesis. So you hold on to null hypothesis. And in the primary endpoint also, it was 0.3, in the cardiac arrest 0.33, serious bleeding 0.9. So that's how p-value should be interpreted, that they should be reported as they are. And of course, interpretation can be done. So as I said, we are now, the important point about the p-waves is that the way p-wave is being looked at is changing very fast. In fact, last year there was a conference of American Statistical Association, which is the biggest, probably the biggest body of statisticians in the world. And they had a big conference about p-value. And the whole concept was how to move to a world beyond p less than 0.05. And at the end of the conference, they brought out a special edition, a special issue of the journal, which is called American Statistician. And at the front, there was an editorial or a consensus paper, so to say, which is about 30 pages, where they very clearly mentioned that this statistical significance word should be totally abolished. they say we should not use this word statistical significance. They say don't say statistically significant. So they write that the ASA statement of the p-values in the earlier, they recommended that we should abandon this, and they say we should mention it very clearly now, that we should stop using the term statistically significant entirely, and nor should the variants such as significantly different or p less than 0.05 and non-significant survive, whether expressed in words or by asterisks or table or in some other way. So because they say that this is not the way it was meant to be, and you cannot depend on entirely on a p-value. There are so many, and there are 43 other articles in the same issue. I will commend that issue to your reading, where again and again they say that we must abandon this concept of statistical significance. And they say that statistical significance enables bad science, statistical thinking enables good science. The p-value requires a context, not a threshold. So the thinking that has emerged is that what we not only require a threshold, we are just totally dependent on threshold of 0.05. We should look at the context also as to why the p-wave was obtained and what was the context, what was the process. So all these things are very important. For example, we are dealing with a situation of COVID today. There are no medicines, there's no treatment which is effective. And you recently saw Dr. Fossey talking about the remdesivir trial, where they have found that there is a trend towards mortality improvement. And based on that trend, it has not reached significance level, but because we have nothing else, patients are dying. So even at p-value of 0.07 or 0.08, we may want to accept the results and reject our null hypothesis that that the drug is working, and we should embrace that result. On the other hand, if you are looking for example, a new statin or a new NOAC, then you need to be more careful. You may insist on getting a better p-value. So this is very important, because a p-value of 0.048 and a 0.052 may lead to a diametrically opposite action. But whenever you do a trial, we must look about the context. That's very important. The process as to how well the trial was conducted, randomization, the scientific rigor of the trial, how good was the follow-up, whether there was any data loss or not. So what is the accuracy and what is the scientific veracity of that p-value, that is equally important. And there is another concept of prior knowledge and probability, plausibility, about the wisdom of scientific explanation. These things are lost when we do a trial in a conventional way. And in this regard, there is a debate between two arms of statisticians. One is called the frequentists and one is called the Bayesian analysis. So whatever we have discussed so far basically is frequentists, and that's the way conventionally we have been looking at the trials, that we just believe the numbers, look at the p-value, whether it's less than 0.05 or not, or whether it's 0.05 or not. And based on the p-value, we have been deciding as to what should be done. Sometimes we take diametrically opposite actions on a very narrow difference in the p-value. So the Bayesians, on the other hand, they say that we must give due consideration to the plausibility, to results of previous trials, to prior knowledge, to the scientific explanation. Everything should be considered when we decide about results of a trial. And in the Bayesian method, the inference of a trial process constantly updates itself. The probability is updated as new evidence is accumulated. So give some prior probability estimate of the previous trials, and then based on the current trial, you come with a posterior probability. So this is the terminology that is used in Bayesian analysis: prior probability and posterior probability. But for the moment, we continue to hold on to our conventional methods of interpretation of p-value. But this is something that is knocking on the door. Now I will discuss last few slides. There are two important, because there are so many statistics which we can discuss, but two things which are repeatedly seen in the current trials, which one is the ROC curve and one is the C index. So what is ROC curve? Now this ROC curve is called receiver operating characteristic curve, and the name is derived from the Second World War days when America had this Pearl Harbor attack, and after that they wanted to improve the radar capability, and so the radar operators and receivers, they had to decide based on the signals whether it's an enemy plane or it's a signal, just noise. So basically they had to differentiate between the signal and the noise, and which can also be interpreted as false positive and true positive. So the ROC curve basically draws this a curve drawing showing the relationship between the false positive rate and the true positive rate. So on the vertical side, we have true positive, which can also be called the sensitivity. And on the horizontal arm, we have the false positivity, which can be called 1 minus specificity. So if you have a specificity of say 0.8, then the false positive rate will become 0.2. So if you find that your true positive and the false positive by a certain criteria are meeting in a straight line at the 45-degree, then that criteria is not valid. That's just a random classifier. What you want is something like this. The area under the curve should be more and more. If you have, for example, the blue line, the sensitivity keeps rising without any rise in the false positives up to this point. And then the false positives start rising. A perfect classifier will be when the sensitivity rises without any, like this purple at the top, which is a perfect classifier. So the sensitivity becomes 100% without any rise in the specificity, without any rise in the false positive. Of course, that doesn't happen, but that would be a perfect classifier. But mostly what we get is something in between, something like the blue line or the orange line, but blue line definitely would be better. So we'll measure the area under the curve, and the test which gives a better area under the curve is considered superior. So when do we create these ROC curves? They are created when we want a binary decision from a continuous data. For example, we have, say in coronary disease, we do TMT, the treadmill testing, and we have ST segment, which is a continuous data. So ST segment depression can be 0.5, 0.6, 0.7, 1, 1.1, 1.2. It can be anywhere, but we have to draw a threshold. And typically we have drawn a threshold of 1 millimeter in the treadmill test. That is where we want our criteria to be set, because that probably gives the best results in terms of false positive and true positive. If supposing you make the criteria 0.5, you want the test to be more sensitive. You don't want to miss any CAD patient. So if you set the criteria of 0.5 millimeter ST depression, it is possible that it will diagnose all patients with coronary disease. It will include all patients of coronary disease, but it will also include a large number of false positives who don't have disease. Similarly, if you take it on the other side, if you don't want any false positives, you want only true positives, and you keep the figure at 2 millimeter, then you will miss a lot of, then your sensitivity goes down. So you eventually you may have to draw ROC curve basically using different thresholds till you find a perfect threshold at which to set your guidelines. And that's what happens. That's how ROC curves are drawn. So I'll show this paper, which is based on cardiac MR findings in patients with hypertrophic cardiomyopathy and atrial fibrillation. So they have used different criteria to find out the risk, AF risk in hypertrophic cardiomyopathy. And they found that the LV mass, and this is the ROC curve, and so they found that the area under the curve was only 0.48 with the LV mass. So that was not a predictor, because that becomes a random classifier. Anything 0.5 is a random classifier. Anything below that is a reverse classifier. Extent of LGE 0.62, somewhat better. LA volume 0.74. This is a good value. Anything 0.7 or above is considered good. 0.8 or above is considered outstanding. Another example. So that's another recent paper. So it says quantitative analysis of late gadolinium enhancement in hypertrophic cardiomyopathy. And they wanted to look at the ROC curve. And here they found that the area under the curve is very good. So this is a very, very outstanding curve, ROC curve, where the sensitivity is very good, 97%, and the specificity is 92% with a very less false positive rates. So that's how we look at the ROC curves. Last thing I want to talk about is C index, which is again a very commonly mentioned statistics these days. And this is basically used to evaluate risk scores. It is something very similar to ROC curves, but more often used for risk scores like CHADS-VASc or ABC death risk score and all that. So it sees their performance. And the way it is calculated is like this. So it's a very small example. So what we do here is like we classify the patients into pairs. So in this example, in the left column, we have patient number 1, 2, 3, 4, 1 to 10. In the middle column, we have risk score. There, say for example, CHADS-VASc risk score. And in the third column, we have the time to stroke. So you draw Kaplan-Meier curves. And when you find there is a lot of censoring, a lot of data is lost, that is when the C index is most effective. So this is the time to stroke. So the first pair, we find that patient has high score of 7 and develops a stroke early at 2 years. And the person with the less score, that is 1, develops a stroke very late. So that becomes a concordant pair, because that's what we expect, that high score means early stroke and low score means late stroke. So this data is concordant. The second one, low score, but it was a loss to follow up. So we have to, and we can't say which one appeared early, so we have to exclude this. The third pair, 5 and 6, low score, early stroke, high score, stroke did not occur. So that becomes a discordant. So likewise, we calculate the concordant and discordant pairs. And the C index is the number of concordant pairs divided by concordance plus discordant pairs. So in this case, we had to exclude 2 pairs. And out of the remaining 3, we have 2 concordant and 1 discordant. So 2 out of 3 are concordant. So the C index becomes 0.66. So this is very similar to ROC curve. 0.5 or less is bad. Anything above 0.5 can be predictive. 0.6 is considered better. 0.7 is good. 0.8 and above is outstanding. So that's a strong model. That's another example where we have this ABC death risk score. This was another paper published a couple of years back where they have tried to compare this new death rate mortality score in the trial population of Aristotle study and Rely study. And this is how they mention it, that the score was calibrated and yielded a higher C indices as compared to the model based on the clinical variables. And they also compared it with the CHADS-VASc score also. So that's how the C indices have been reported. As you can see, the CHADS-VASc score had a C index of 0.59, while the ABC death had a C index of 0.74, which was much, much better as compared to the CHADS-VASc. And whenever you find that the score is, and of course, all these scores also have confidence intervals. And if the confidence interval includes 0.5, like here in the last row, 0.5, it shows 0.48. So this becomes non-significant. We don't attach much significance to it. So I think I will stop here. Maybe some other time we can discuss the interpretation of meta-analysis, survival analysis, and of course correlation and regression, which are very difficult concepts, and of course non-parametric tests. So I think I will stop here. Thank you very much for listening. Thank you very much.
Anil, this has been a wonderful, very, very clear talk. Really excited to listen to this.
Thank you so much.
I think I'll rather now request Sanjeev to give his comments.
Well, I think what you've done in this presentation is to make something cogent and clear, and with your examples, you have made it extremely relevant to what we've done. Statistics, though it's called an exact science, is actually an inexact science, and it is a science where you have many different ways of looking at a problem. And as you just showed in that article from the American statistician, statisticians have realized that it is the sum total of probabilities from different pieces of data that lead us towards truth in answering a question. So there's no one piece of data that defines the complete truth. And I think that is so to just give you an example in that, we used to do mortality trials for a very long time. And what we found was that mortality trials were difficult to do, required very large numbers of patients, simple in the matter that, as Salim Yusuf used to say, you could always count a dead body correctly. So that's true, but they are very difficult to execute, and you pointed that out in the size of the trials. So we came up with the idea of what presages a mortal event, and that's a cardiovascular hospitalization. In heart failure, it's a heart failure hospitalization that leads to a heart failure death eventually. So we've now added these things into the primary outcome. So the CABANA that you mentioned had a pilot. And originally designed as a mortality trial, it modified the primary outcome, as you said, that it took one of the secondary outcomes and added it into the primary outcome to try and get more events, get more clarity on the direction the data was going. And I think directionality is really important. So it's really important for us as clinicians to understand the statistical bases of these different tests and concepts, because as clinicians, we are used to seeing a patient in totality, their history, their findings, their events in their life, things that put them at risk to arrive at a definitive diagnosis. Statisticians are slowly coming in that direction as well. So as you see all these, you've outlined a significant number of important tests. There are more that you'll probably talk about, I hope, in the future. You take all of that and you arrive at a belief that this is leading us somewhere or not leading us somewhere. And I think that is the amorphous side of statistics that I think we all learn to appreciate. So I think this is a wonderful start to this discussion. I think you've made this cogent and clear and clinically applicable. And I saw some questions from people in the audience that I think we should pose to you at this point, and then perhaps you could answer that. A couple of them you answered, like on the issue of the C statistic and the area under the curve. But so there was a question asked about the difference between univariate and multivariate analyses and the log rank and Cox regression. Now, they're not exactly totally in line with what you were discussing today, but maybe you could make a brief comment on that.
Yeah, so log rank test is basically done when we want to compare two survival curves. So you have these Kaplan-Meier survival curves, where we basically draw these curves as people either mortality curves or anything when the patients are free of certain event or outcome. We draw these Kaplan-Meier survival curves, means survival free of certain outcome. It could be mortality, it could be some other event. And when we have to compare the two survival curves, so you have, for example, a treatment group and you have a control group, and both have their own survival curves, Kaplan-Meier curves. And you want to compare the two, whether there is any difference or not. And that's when you do the log rank test. As far as the regression analysis is concerned, that's a complex topic. It will, I cannot give a very cogent answer in brief, but basically regression means that you see, correlation is when you have two variables and you want to compare the two variables, whether they have a relationship with each other or not. So that's when you establish a correlation between the two. And the correlation coefficient could be 0 to 1 to -1. 0 means no correlation, 1 means perfect correlation, and -1 means reverse correlation. So that's how you draw the correlation statistics. Regression means the ability to predict a particular variable from the other variable. So over a time, you can predict from one variable, you can predict the other variable, what it is going to be. That is called regression analysis. And what was the third thing about, sir?
So they were asking about univariate and multivariate
Yeah,
analysis.
so univariate, again, it depends on the number of variables that you're analyzing. That is depends on univariate and multivariate analysis. It is something that I cannot answer verbally. Maybe I will need some props for that. So maybe some other time.
Yes, I think both of those, go into future talks.
Yeah.
But I think returning to your original slide of CABANA,
Yeah.
looking at the per protocol or intention to treat analysis or on treatment analysis as been used by others, when you remove those patients from one group or you transfer them from one to the other, as you pointed out very correctly, the randomization hypothesis is then in
Compromise.
question. And then the question comes, how much imbalance have you created in those two groups? And you then look at those two groups and you look at them for imbalance, and then you try and do corrections from that for those variables that are imbalanced to arrive at adjusted risk ratios. So the multivariate analyses are designed to make those corrections. And I think that next time we can discuss this very carefully. But I will point out one thing about randomization. I'm sorry April Slee is not here and George Weiss are not here. The three of us have debated this for years. I once told George that, randomization is done on basis of what you can see. It is not done on the basis of what you can't see. So if you take atrial fibrillation and now everybody is measuring AF burden, it has now become, and Luigi Padaletti unfortunately is no longer with us anymore, but Luigi and our work with devices in atrial fibrillation showed that there could be a 10 to power 3 difference in AF burden between groups that looked homogeneous on entry into a study. So did we balance groups for AF burden in all our atrial fibrillation trials? Does that mean something in terms of should that be assessed? It's a variable we never put into any clinical trial. So even, to my mind of thinking, and I'm not a statistician, I think that, so the response I get from statisticians and George is that if the group is large enough, randomization would correct for that. But as you showed in your slide with the two circles, 10 to the power 3 is a huge amount of difference. You need a really big circle to get around that, and we never can implement these sizes of trials. CABANA took how many years to enroll those patients?
It was a huge effort.
So the practicality of achieving these statistical principles in biologic models is a little bit of an issue. I'm going to stop there, and there are questions further questions from the group. TS, do you have questions? Oh, there was a question on NNT and sample size calculation. Do you want to address that now? Or
no, not really. I don't want to get into the calculations part right now, because that is something I will leave to statisticians, because what we want to discuss here is, because that will confuse everyone. I may not be very good at it also. I don't even know how to calculate sample size. But the whole idea about this particular topic was that all of us must know when to do a particular statistic, use a particular statistic, and how to interpret it for our day-to-day practice, and some of us have taken, for example, assignments which require them to review manuscripts, so unless we know about the statistics, unless we know about the complexities or intricacies of the trial methodologies and randomization, we may not do a competent job there. So it's very important for us to, when we review any trial or when we read any trial for our own knowledge, we must know how to interpret it by looking at the statistics that has been provided.
Yeah, and I think that's absolutely right. I think the one paragraph, I've always said to the reviewers, I was told this a long time ago by mentors, that if you're going to review a paper, if there's one section you must read, it's the method section.
Yes.
And that's the reverse of, we always go to the results. As far as the power thing, for clinicians to really know, I think most statisticians would consider that anything under 80% power becomes a weak trial. 80% is usually considered reasonably robust. I've presented trials where they've told me that 90% is what we are looking for, and the reason for that is because trials always fall short of what reality is. So if you have a sample size on 80% and you have dropouts and censored patients and all of that, you fall, and in that sample size calculation, you usually allow for a certain percentage of dropout, 10%, 5%. And, the statistician asks us sometimes what you think the dropout rate will be. And once you calculate that in, even then you fall short. So some people push for 90% power and trials, but you should at least know when you see the trial design that it's at 80% power. That's usually considered reasonably acceptable.
Because you have to look at the logistics, about the numbers, about the cost of the trial. So, and of course the power. So one has to find a sweet spot as to what can be the adequate number, because in some trials it's very difficult to even get enrollment of good number of patients. So one has to find a nice spot where you can keep the power and enrollment number and everything together.
I think somebody asked the question of why more and more non-inferiority trials rather than superiority trials. Yes, this has something to do with the probability of getting superiority trials, positive trials. The non-inferiority trials are more likely to be proven correct.
Yes, definitely, because in non-inferiority trial we are having advantage of a delta, that is the non-inferiority margin. Right. So the drug to be proven non-inferior has to be significantly inferior, and if it is not significantly inferior, it will be considered non-inferior and will get approved. So it's easier to get approved.
Absolutely. Any more questions, Vanita, from anybody?
So the questions are on the chat.
Anything you want.
Can I see the chat now?
So there was a continuing question around non-inferiority trials as to how do you decide about the non-inferiority boundary, and somebody correctly answered a basis of prior data, but also basis on clinical significance. So you might decide that it's very difficult to interpret a 1% difference in embolic stroke rate as being a substantial change, and you can set a boundary of 1%, 2%, whatever you consider is clinically significant, and the statisticians work backwards to decide that anything less than that is non-inferior.
Sanjeev, considering the statistical evaluation and statistical thinking has been changing progressively, as Anil showed some of the new thinking, like even rejecting the p-value concept. Won't you think that a lot of data which is published before it may or may not be correct statistically? And whenever we want the literature review, or we want to learn what has been published before, everything written in the literature is not the word of God. I think that's what we need to realize as well.
Yeah, I think that you can't discredit all prior work which was observational by just because we didn't do all of these things. So I think the next subject that Anil was going to talk about kind of speaks to that issue, which is when you have different distributions of data, when there are when can you use a historical control for comparison? What are the pluses and cons of historical control? So, and there is an argument in statistics that that randomization can be unethical in certain situations. So I think this is something I think if you continue this line of lectures, Anil, I think we can all kind of get into discussing these things.
I think it's a great thinking. I don't know whosoever has thought about this kind of lectures, Anil himself or somebody else. I think it's a great credit.
Thank
And
you.
we will certainly, all of us will learn more about the research methodology, how to interpret papers, and how to have a better information type of treatments we give to our patients. So wonderful, Anil.
Thank you very much. Thank you, sir.
Thank you, Anil. It was a wonderful, clear expose.
Thanks a lot,
Very hard thing to do with statistics.
Thank you so much.
So
yeah, it was a great talk. Thank you so much, Dr. Saxena and
Thanks,
Dr.
Vanita.
Claire and Dr. Anil Saxena. Wonderful presentation. And we have a last comment actually from Dr. Paul Chaco, that good to apply this concept in the setting of COVID trials, the new drugs being tested.
Right.
The non-inferiority and the whatever you explained. He has said that I think we should be applying it on the new drugs which are coming for the COVID trials. So that's good. On this note, I would just like to add that Dr. Sanjeev Saxena is being honored. Indian electrophysiologist is being honored at HRS. I think tomorrow probably, sir. So heartiest congratulations to you, sir. And I would like to request you to please say something on that.
great.
Thank you very much, Vanita. It's very humbling and perhaps an experience that you get in your lifetime, that so many people who you have collaborated with over more than 35 years, a line of work that we espoused almost 40 years ago, that the body of work is recognized, and it's recognized by a generation after me. It's very common from people in your own generation to appreciate what you might have done, but it's more important that if people after you get to see that. And there are if we had a face-to-face meeting, I would have recognized people who have worked with us over 40 years. I actually reached out to some of them from 40 years ago to talk to them about the fact that things they had done that time are recognized and still relevant. And it's nice to have younger colleagues look at these things and think they're worthwhile. So thank you very much for mentioning it. And I think the more important thing is that all my collaborators over the years who actually made this thing happen and believed in the idea that non-pharmacologic therapy of tachycardias was possible. And when I came to work with Victor Parsonet, that was it kind of was a bad word to talk about non-pharmacologic therapy of tachycardias. People thought it was ridiculous to think of burning heart tissue and using devices. And Dr. Mirowski could not find people to do a clinical trial with him. I have this Twitter debate going on with George Weiss, and I pointed out to him that the randomized clinical trial, which was my idea with Salim Yusuf, was done 15 years, was reported 15 years after the defibrillator was actually invented and used. So I think there was a COVID comment, and I'll say something to that point. It's somebody's observation that sets up a direction of work. They develop certain amount, and then a randomized clinical trial will prove the strength of the concept, not necessarily its validity, but its strength. And so that's a long answer to your question, but thanks for. I think anybody who has an idea which is not in the mainstream, it is not conventional thinking, I encourage that. I think you should do that, believe in it, pursue it, and then you will make it happen. If it's real, and you have the information to back it up.
Thank you, Dr. Saxena. I think what you said about the next generation honoring you, that is the transition you have made from becoming a good electrophysiologist to a legend in electrophysiology. That's why you're being honored so nicely, sir.
Congratulations.
It is a proud
sir.
to be there. Dr. Saxena, Dr. Anil Saxena, you want to say something, please?
Yeah, I just want to congratulate him, and we are so honored to have him with us today. And we are actually missing. This time we missed out you being honored there in the event, because the event was cancelled.
Yeah,
but would have loved to be there.
Sanjeev, we don't consider biological age very important. Your brain age, I think, is less than 25 years, so you still remain part of the younger generation.
Well, I think the new ideas keep coming, and I think we need to foster people who want to investigate and pursue new things, instead of trying to just say that, well, we don't have a randomized clinical trial, so we can't believe anything that can be said. And I've long been a proponent of thinking outside the box, and I hope that the young people on this conversation today will not let the RCT daunt you. The RCT will come once the concept is mature.
Sanjeev, I would also request you and many others senior to somehow instigate, encourage fundamental research in India. I think that's the thing which we are still behind, and somehow or the other, if we can, I don't know, the younger generation has to be more interested. I don't know how to do it, but that is something which is lacking in our country. I'm very, very clear that Indian brains are very good. They are very good physicians, electrophysiologists, cardiologists, interventional cardiologists. But still, the original research coming from India is limited. So that's what we would like to see happening. And I don't know how to do it and how one should go in this direction.
I owe my career to Sujoy Roy. Sujoy Roy was the chief of cardiology at All India Institute, and I was a second-year medical student looking for some research areas that I liked in biology. And Sujoy took me under his wing and got me started. And the research I did with him, we even published it posthumously after Sujoy was no more. And so it is all about mentorship, and it's all about showing that medicine is much more than a busy healthcare organization running through its daily activities and its whatever its structural activities are. That I mean, the kind of lecture that Anil gave today makes us think about how many pieces of data have come through, and we have not looked at them in that way. And some young people will look at that and say, I want to look at this, I want to come forward. And when they come forward, the job of the chief or whoever is involved is to say, to foster them and grow. So I'd love to come and try and see what we can do. I've not given up. I actually did come back to India in 1980 to try and set up an EP lab, or time was not there. But I think it's very much possible. All of you should, now that you are functioning as a large collegial group, maybe there should be a small think tank that works on how to create the mentorship opportunities. And one of the things that one has to think about, it doesn't have to be research driven by industry. It can be research on concepts, fundamental disease states. And in fact, India has a great deal to offer, because you have a lot of disease that can be studied for a lot of things.
Yeah, sure.
Thank you so much, Dr. Saxena. This was an excellent, suggestion. And I just want to add here that under the leadership of Dr. Anil Saxena as the president and Ajay Naik as the vice president, we have taken over research very, very seriously. In fact, Dr. Namudri has worked a lot on creating, groups amongst the executive committee as well as IHRS members to start a lot of research products and research projects. And we are working on it. We are working towards that direction. But yes, of course, we will always require your vision and your mentorship to be guided further. But I must say hats off to Anil as well as Ajay. They have really worked very hard on this. The executive committee of this year has really worked hard on this. So at that note, sir, I just
one small comment from me.
Okay,
Vanita.
Ajay, yeah, please go ahead.
Yeah, just one small comment. Dr. Saxena, thank you for being here. And sometime in the future, whenever it is convenient for you in the next few weeks, we'd like to hear from you regarding mentorship. That is something we really want to be remodeled, what is done in the US, Europe, and how we can apply that to India. And
that's an excellent suggestion. Please go ahead, Ajay. Please go. Yeah.
Yeah, so I'd like sometime, whenever possible, Dr. Sanjeev Saxena can give a talk on mentorship and how to go about it in our country.
Dr. Saxena, can you spare the time, Dr. Sanjeev Saxena, please?
I'll be happy to. I can only use my own examples of people who taught me.
Sure.
And how they taught me, and what are environments, and I think we can talk about that. And but I will need some time to frame it in an articulate way.
Sure. I will get in touch with you for that, sir. I will coordinate that. It will be a proud privilege to have you for this topic, of course. And sir, there is, I'm sorry, I know this is a very sensitive topic for you because you've just had a colleague's loss because of COVID. I read it on Twitter. But there are a couple of questions. One was from Ajay as well as from Nishit Chandra on the chat. They want to know about the situation of COVID in US from you. So if you could please highlight that.
So I think what is going on is a situation where a disease that we really don't understand in detail is affecting a very vulnerable population where infectious disease has not been part of its experience, and the immune status of the population here. What you're seeing is a lot of discussion around this disease, which really reflects the fact that we don't understand the natural evolution and history of this disease. And that is understandable. It's a disease of less than a year's duration in clinical experience. So and the second fact, which is immutable, is that there is a huge population that has been exposed to it here, mainly perhaps because we are doing very extensive testing. And there is a substantial mortality rate, which may be related to many factors, one of which may be that we don't have a lot of infectious disease here. So I think the COVID situation is, what I think has happened is that the basic public health teaching that used to take place. I mean, I remember doing a 6-month course at All India Institute on just public health in second MB, as they called it, and those things have not been part of the experience here. So things like that are being done now, public health measures are slowly reducing the spread and of the disease in the areas that were affected. But they've not been enacted uniformly. This is an issue of public health education of the population. So I think this epidemic really points out that public health teaching in medicine and outside the medical profession is really important, starting from schools, starting from college. Everybody needs to know some biology and some public health. And I think the fact that it has taken a secondary role to information technology and other things in schools is showing up now as a very big weakness in coping with the disease. I mean, even among all of you, I think there's only a couple of us who saw smallpox or who saw diphtheria in an epidemic form. So there is not a lot of institutional memory. So I think what we've got is we need to understand this disease. There's now information suggesting that the new mutations are more contagious than the original mutation. The new mutations may have come through Europe into the US, into the East Coast. We've had a very bad time of it. The West Coast is perhaps got the original mutation and it's doing a little better. But the most important thing we have to do is to understand the nature of this disease, and doctors at the bedside who see these patients from beginning to evolution to either resolution or death can describe a lot of clinical data that will make us understand the disease. And that is what's really missing, that somebody who can describe the disease from beginning to its either terminal situation or its resolution, and understand each phase. And then we know what we can do to intervene. You know, I know there's a lot of argument about observational data from France and randomized clinical trial. We don't know where to apply these drugs, in which phase of the disease are what drugs useful. Are we even talking about the same disease at all phases? You know, so I think there's a lack of, I think this is a lesson in humility, that illnesses are understood over decades, and you know, right now it's a holding action, but things are getting better. I mean, I think it's far from done. I mean, I think public health education is the biggest part of trying to get some stability in the epidemic, but I personally don't believe that this is going to be any better for about a year to 2 years. And I think this virus has been here since last year. So I think there's been a huge underestimation of this, of the propagation of this virus. You know, I always tell this example. You know, we all got bitten by mosquitoes in India, but not everybody got malaria. Now, did every one of us get bitten by a male mosquito and who didn't get malaria, or a female that didn't carry the parasite? Of course not. It's a matter of exposure. How much exposure did you get, and how's your immunity? So I think that applies to COVID as well. And one of the only lessons I'll tell you is, if you come to these patients, do the essentials, but please don't expose yourself and your staff for long periods of time to an individual active patient. 5 minutes, 10 minutes, do what is necessary, step away, come back again and do what is necessary next. Do as much as you can at a distance. I think you have to observe those basic precautions, and it's part of our loss of life has been because there are people who have rushed in, who have not been protected well, who have not watched their viral load exposure.
Yeah, thank you so much, sir, for your wise guidance. Of course, I would say this time of what should I say, biological terror. I don't know whether I can use that word or not, but it is turning out to be a pandemic which is very, very scary. So I really don't want to end it. I am really enjoying this, but as you know, it's been 1.5 hours, and I think everybody has to work off. So what do you say, Dr. Anil Saxena? Should we call it off? With your promise, of course, that you are going to speak on that topic very soon to us.
Thank you, Vanita, for organizing this.
Thank you so much.
Thank you, sir.
Thank you, Dr. Claire. Thank you, Dr. Anil Saxena. You want to say something, please?
No, but thanks. Thanks a lot.
Okay, signing off, please. Thank you so much, everybody.
Thank you.
Good evening.